Right, so I think I'm going to crack on. Thank you very much for attending. Can I just quickly confirm again? You can see my presentation.
Yes, we can see your presentation.
Brilliant stuff. Thank you very much. Right, so in relation to my QIPs, this is all right. I don't think that was the best of the beginnings, but let's see. Right, in relation to my quality improvement projects, this is one of the projects that has been very close to my heart all along. Unfortunately, I couldn't start it initially because the COVID pandemic hit, and then it got we had a lot of hindrances as a result of it, so it slowed down quite significantly. When I was an F2 and SHO, I always found it very stressful if I was asked to prescribe a variable dose intravenous infusion prescription. For example, aminophylline is used very often on the medical take. Dopamine, dobutamine are not unheard of. GTN infusion is also another one used commonly. And over at Eastbourne side in our stroke units, we use labetalol, not that uncommonly. So the things that we are not used to on day-to-day basis, but then every now and then we are expected to prescribe them. The stress essentially was that the amount of the time it would take in order to prescribe it, and number two, am I taking all the factors into consideration that are needed in order to write a safe and comprehensive prescription. When I started working here in East Sussex Hospital Trust, I realized that we did not have any protocols available, or if we had protocols available, they were not easily accessible. So I was not able to access them, let's say, standing in the recess where I need to start some drug imminently. So hence the idea to maybe introducing some pre-formulated standardized prescription charts for the drugs that require variable dose intravenous infusion to try to make it more time efficient, safer, less stressful, um, and to make sure that any factors that need to be taken into account before starting any such rare prescriptions are actually been taken into account and haven't been forgotten by virtue of their rarity. Started this project with me as the lead, supported by Maham Beg and Aisha Bilal, who are two very brilliant and hardworking SHOs over at DGH site. Essentially, errors and discrepancies in the intravenous infusions are fairly common, as shown in this observational study, where they reviewed about 2,000 infusions, out of which about 1,000 had errors and discrepancies. 23 errors, so 1.1%, were considered potentially harmful. Conclusion-wise, they are not uncommon. They occur frequently, and as we can see here on this chart, so the errors can be as frequent as less frequent as 2% to as high as about 24%, but the discrepancies can be between 14 to 100% based on where we are working. Main errors are seen essentially in what dilution, what strength are we using? So what diluent and how much is being used? What is the rate of infusion? And if we have used the wrong dosage, particularly if the dose needs to be adjusted to their weight or their age or their renal function or according to some other variable. Inappropriate choice of solvent is also documented to be one of the most common error in prescribing such drugs. So somehow that, all right, yeah. So how do we risk manage it? Essentially by making it Right. Essentially, by formalizing some standardized infusion protocols that follow our trust guidelines, and then hence it should reduce the error. Rationale behind the project, as I said before, that we lack any such clear guidelines, and where we do or we have protocols, they are not easily accessible. Number two, as we are all aware that trust will move to EPMA, the electronic prescribing, fairly shortly. The pilot has either already started or will start shortly over at DGH site. And that EPMA lacks the capacity to accommodate variable rate infusion. So we need to have a paper format of administering these drugs anyway. Combine it with the rationale that I gave earlier on. We came up with the idea of making these protocols that would serve as a prescription for the doctors, the administration chart for the nurses, and will include important advisory on it so that we remember them. It would just act as a reminder. So this has already been discussed. It is expected to reduce medical errors, and it would ensure uniformity and universality. Just making a passing comment, in my last 9 months here, I have seen prescriptions of aminophylline being prescribed as aminophylline 350 milligram IV stat. Now, of course, we expect the nurse to understand that, we should be giving it as per the protocol, and vast majority of the nurses would consult Medusa anyway. But in all fairness, it is an inappropriate and, frankly speaking, dangerous prescription. If somebody take the word for it, right, giving somebody 350 milligram of aminophylline as stat is very, very, very likely to be fatal. Right. So taking aminophylline as an example, I'll prescribe the data that we have collected. The chart would look more or less like this. This chart would be made available on intranet, so people should be able to download it from there. The chart has a space for patients' demographics. So addressograph here, it asks for patients' weight. We would fill in the rest of the details, is what are the patient's allergies, and for the person who is prescribing it to let the nurses know when to contact the doctor, besides using their common sense. It also gives us patient's ideal body weight, and based on patient's ideal body weight, what strength would be needed to administer for loading dose, and what strength would need to be administered for maintenance dose, and at what rate. Meaning thereby that if I want to give a 70 kilogram chap in A&E a loading dose of aminophylline, that would be 350 milligram. And when I would start him on maintenance dose, that would run at 35 mils per hour. So pretty much self-explanatory. It already calculates the rate and the dose, and all essentially we need to do is correlate with patient's ideal body weight. The prescription for loading aminophylline, right? We already know what solvent we are going to use and how much, so that doesn't need to be changed and hence can be left there. We already know the rate that it needs to be administered at the loading dose. So all I need to do is, based on patient's ideal body weight, after seeing here, I write down that dose of aminophylline here, and I date, time, and sign it, and the nurse should be administered it. This is followed immediately by a very prominent highlight, which points out that if the patient is already taking oral theophylline or uniphylline, the loading dose should not be given. Now, this is one of the errors which we very frequently, which I have frequently come across, seeing that the rationale being that patient already has aminophylline or theophylline in their system, and if we load them again, there is a risk of getting toxicity. Then we prescribe our maintenance dose here, as you can see, the diluent is already there, the concentration, we already know what we are making. All I need to write is the rate of infusion based on this chart, sign it, and maybe give a minimum and maximum rate. This has the references here which are being used to develop this. This is where this is what nurse use as administration chart for the maintenance dose, and then we have some recommendations here. Recommendations include that please be aware that in acute porphyria, aminophylline is contraindicated. For obese patients, it's the ideal body weight that needs to be used. And then, of course, we need to check for allergies. Interestingly, if somebody is allergic to caffeine, the person will cross-react to aminophylline. So that's an interesting point, just as a quick reminder. What monitoring do we need? It's mentioned here. How do we monitor the therapeutic drug levels? Very clearly documented, and hence it is expected that we would be improving our practice of monitoring people's therapeutic levels before they give us any signs or symptoms of toxicity. So this is just a, let's say, example of the charts that have been developed, which would require formal approval from pharmacists, which we are in the process of, pharmacy team, which we are in the process of. And once it is approved, then they will be made accessible via intranet and would be good to go ahead for usage. Data wise, we used some asked people to prescribe these drugs for us without and with the presence of these new charts, and then ask the nurses to try to administer them, of course not to real patients, just as an exercise, right, using the charts which are being prescribed without using our let's say with our current practice versus this new proposed method. And then we use some questionnaires as well to assess their comfort level of prescription and how much time has it taken. So let's say for the doctors, we gave them this scenario, which is fairly simple. 66-year-old, known COPD. You have been asked to start this patient on aminophylline, and that was the scenario. We did have the rest of the scenario, which was not volunteered. Only if the people would ask, we would tell them what their ideal body weight is and that they are taking oral unifiline at home. So it is just to identify that these are important factors in aminophylline prescription, but these are the things which, because we don't use them frequently, we often tend to forget. Using this scenario, we use 10 doctors to make to write the prescription for us using whatever source they wanted to use. Right. The time taken is surprisingly longer than what I expected. It looks like 50% of the people took about 25 to 30 minutes just to sign the prescription, a prescription that they were happy with. About 20% took 15 to 20 minutes, and 30% of the people actually took 30 to 45 minutes just to prescribe aminophylline. 90% of the people used BNF, and one of the person, so 10% of the people who used other resources like online protocols. They looked for online protocols to see what is the right dosage. Out of these 10 prescriptions, 70% did not prescribe the loading dose right, 50% did not prescribe the maintenance dose right, and this is actually the surprising area, that none of the people who have made this prescription identified that the patient was already on theophylline. This is while using our standard current practice. Which, as I said, like if somebody's taking, so it loading dose should not be given because it dramatically increases the chances of theophylline toxicity. Just demonstrating our theory that it can be like most of the prescriptions are incomplete, and then it can be dangerous as well on occasions. Now, then we use the same charts. We took them to the nurses and just asked them as an exercise to take whatever time they need to take and use whatever resource they want to use and draw up the aminophylline infusion as per the prescriptions which were prescribed by these 10 doctors. Now, again, timing wise, take a look. So 40% of the nurses took 20 to 30 minutes to set up the infusion, and rest of the 60% took 30 to 45 minutes. So overall, from the time of conceptualizing that we are going to start this person on aminophylline, if a doctor takes 45 minutes, then a nurse takes 45 minutes to start administering it. That's 1.5 hours before that idea gets put into practice, right? And then almost all the nurses had to consult Medusa in order to find, in order to be sure that they are giving the right thing. Now, again, talking about loading dose, so 70% of the nurses, did not manage to set it up correctly. And when we say set it up correctly, what we mean is not all the factors were taken into account. So, for example, only 40% of them took into account patients' weight. Of everybody was able to find the right solvent, but only 3%, 3 or 30% were planning to give the right dose, to bear in mind that the dose that was prescribed by the doctors. So initially, if the dose prescribed was not wrong, they were unable to identify that initially when the dose was prescribed, if it was not right, the nurses were unable to identify that it's an inappropriate dose that we are giving. Similarly, 60% were able to set up the right rate, and only 50% considered the allergies. Again, the nurses also failed to identify that the patient was on oral theophylline, and hence the loading dose should not be given. So if I have overlooked it and prescribed it, that dose was going to be given. So there was no second line of defense to identify that maybe loading dose should not be given. Similarly, these are the values for the maintenance dose. Again, 70%, only 30% actually managed to set it up correctly on both accounts. Next error. Oops. Next. Oh, is somebody trying to take over the presentation from me? All right, I'll crack on. So error in prescriptions picked up and highlighted by only 20%. So if I have made a mistake, it was highlighted by 20% of the nurses that, oh, maybe this is not right and hence should be corrected. 80% of them would go ahead and administer it as per my prescription. So the next step of the project was essentially finding the satisfaction survey. How satisfied or comfortable did people feel using our current standard practice? All the people do not feel confident at all in prescribing aminophylline infusion, talking about the doctors, right? 60% have never prescribed aminophylline, right? So this was their first practice. Nobody knew the exact regime of loading or maintenance dose, which is understandable. It's a rare prescription. It's dependent of very many factors, right? And 90% of the people think that there is like if there was a pre-formulated prescription like the one which we use for heparin infusion or for variable rate intravenous insulin infusion, it would make prescribing more efficient, less stressful, and safer. And then everybody was trying to use some resource anyway. So either they were going to BNF or they were trying to find online protocols to refer to before signing their own prescription. And everybody, all of the doctors think that the practice has a lot of room for improvement, our current practice. Once it was asked that how would you monitor the aminophylline levels? So 2 people and 3. So 3 out of 10 people, so 30% of the people were going to get it done correctly. All the rest were either not sure or were planning to do it inappropriately, the therapeutic dosage monitoring. Right, nurses, more or less the same story, right? Almost all of them think that they don't know how to, like they don't know the regime by heart, which is very much understandable, right? They shouldn't even there should be a resource to be able to refer to. They would refer to Medusa or any other resource in order to set up the drug. And this one here, that how easy is it to calculate the concentration and subsequent rate of infusion, right? 40% would say it is difficult, and the 60% thought it was fairly easy, and 80% agreed that there was room for improvement. Again, as far as checking the levels was concerned, nurses were doing a little better. So about 40% knew that should be checked at 4 to 6 hours after starting the infusion, but the rest would not have checked it at appropriate time. Again, everybody, as I said, nurses, doctors alike, thinks that the practice needs improving. Now, same scenario was used for part B, but this time we used our proposed aminophylline infusion chart, which I showed you earlier on, and the results showed dramatic improvement straight away. Now, important to point out, these are not the same doctors and not the same nurses. So the first practice was done with 10 separate doctors and nurses, and the second practice was done with 10 separate doctors and nurses, right? And these people had not seen this prescription, which I've shown you before, like beforehand. So it was a new thing which was handed over to them saying, if you are able to download this from intranet and you're given this scenario, can you please prescribe them and all. So the timing of prescription had reduced significantly. 60% were only taking 5 to 10 minutes to prescribe, 40% 10 to 15. So we can say that we have brought the time down from 30 to 45 to 10 to 15 maximum. So that's a dramatic improvement in making it much more time efficient. Resources used, nobody need to use any other resource other than the chart because it already had an advisory on it, right? Everybody got everything right. Why? Because essentially most of the things are already prescribed, and as far as the prescription itself is concerned, it is telling you there in the form of that top right hand corner dose calculation as per ideal body weight. People did look for oral theophylline because it says there, do not give the loading dose if the person is on oral theophylline. So people did ask for it, right, and adjusted the prescription accordingly. So dramatic improvement just by introduction of a simple piece of paper. Now, for nurses, time taken to set it up, 40% 5 to 10 minutes, 30% 15 to 20 minutes, which was the maximum time people took, and 30% had taken about 10 to 15 minutes again. So time down from 30 to 45 minutes to maximum 15 to 20 minutes, which is again time efficient, and people did not need to use any other resource because the solvent was there, the dosage was there, the advisory was there on the, so hence it saved a lot of time. Again, everybody was able to identify I mean, I shouldn't say identify because there was no discrepancy in the prescription to begin with anyway. Having said that, what is being administered is exactly rightly adjusted to weight, dose, rate, allergies, and if the person is taking oral aminophylline. So remarkable improvement. Error in prescription picked up and highlighted, as I said, so there were no errors and hence like there was no need of picking it up. But I am sure if I accidentally prescribe it wrongly by virtue of the chart, because it's a fresh pair of eyes, the nurse who's administering it, they probably will be able to highlight it. Survey, second time, right, when we did it. So how comfortable did you feel? It has literally flipped from not comfortable at all to very comfortable and confident. Would you refer to any other resource? 40% still would refer to a different resource, which is good if they want to counter check things. This is brilliant. However, 60% thought there was no need, right? And people thought that it would help reduce errors. People thought that they would prefer our prescription chart for prescribing, and that it does help to reduce time, which we have proven anyway, right? It does reduce stress according to all of them, and then it still, like, if the prescription and the practice around drugs can be improved, everybody agrees with it. Now, everyone, right, was able to identify when to check the theophylline levels. Why? Because it says there on the chart itself, right? Nurses wise, again, you can see everything is very comfortable, very easy. Standardized protocol is preferred. It was easy to figure out things, right? About 20% still would refer to Medusa, which is good if they want to counter check things. It is good practice, right? And yes, everybody thinks that we should be able to improve the practice by introducing these charts. Everybody managed to find exact timing of checking the levels, for again, because it says there on the prescription chart. Conclusion: our proposed prescriptions are expected to ensure uniformity. They are expected to reduce errors and discrepancies in real life, as well as it is documented in some data which is published, and as we have just shown with this little exercise. It is expected to be time efficient. It is expected to be less stressful. For, like, for example, I mean, I being the respiratory registrar, what do I know of dopamine or dobutamine prescription? So if I have something as self-explanatory as this, it would make my life very easy. It would make it less stressful when I'm on call. It is pretty much self-explanatory, and we will make it easily accessible when they are formally approved via intranet. So once EPMA comes in, they'll be available on intranet and will be accessible to be downloaded. If there are any questions, I'm happy to take them now. Thank you very much for your patience. Yeah, please unmute and speak, please.
Yes, hello, my name's Rosie. I'm one of the pharmacists.
Hi, Rosie.
Really excellent piece of work, and your ability to demonstrate the improvement in prescribing and the safety for patients and the confidence for staff is really exciting to see. My only plea would be if I understand they're going to be approved, which is fantastic. If they're going to be available on the extranet, it's really helpful if they are a Word document rather than a PDF document, because that does allow then typed information for patient details or doses or things if you wanted to do that. Whereas if they're a PDF document, you have to print it out in order to write on it. And sometimes, we know speed is of the essence at times like this, but really excited to see your work and looking forward to seeing them coming for approval.
Really appreciate your kind words. Thank you very much. Well, either I have stunned you with the work which we have done, me and my team, or I've just read you a lullaby and everybody is asleep now. Thanks, Addy. Oh, can I say out of the doctors who are actually attending currently and still listening? So to begin with, we have aminophylline, dopamine, dobutamine, isoprenaline, labetalol, GTN, NAC, isosorbide dinitrate, which needs some work still to be done on it, and one more. Which one is that? Heparin. So heparin is already running. It just needs a little tweaking in it, and that's it. So that is already approved. But if somebody is interested in becoming a part of this project, it has room to make tiny prescriptions as a QIP on its own anyway. So please do get in touch with me. It's a 2 hours job, easy to be done, would look nice on your portfolios and stuff. I can give you examples. For example, you may like to develop something like adrenaline, noradrenaline. On cardiology unit, they use very many things, which I must say the last time I read about was in medical school, like apiximab or tirofiban or tirofiban or whatever we pronounce it. Like, that's my knowledge of cardiology drugs. So if anybody is interested, well, as I said, it's no more than 2 hours work. I'm telling you by personal experience. We as the team have developed most of these prescriptions, and it would really be a nice, quick QIP, right? And we can build up on the number of the variable rate infusions prescription that need to be there for on-take team, like on-call team. Right, I understand there are no more questions. I really appreciate you guys taking time to attend. Thank you very much, and have a lovely day.